Hello friends and welcome back to Percetis Chronology. In today's video, we are going to study regarding Goal 2022. What are the newer changes in the Goal 2022? Goal 2022 is a body which forms a guidelines for chronic obstructive pulmonary disorder. And the newer changes have been divided into three major headings. That is the newer terminologies. Second is what are the management aspects. Third is what is SIT therapy. Okay. The terminologies: early COPD. The word listen carefully, it's a very important terminology. The word early means near the beginning of a biological process. Note it down, it's a biological process because COPD can start early in life and can take a longer time to manifest clinically. So identifying early COPD is very difficult because it's a biological process, and hence early COPD should not be used in a clinical context. Important, it's early COPD is a biological process, not to be used in a clinical context. That's the first term. Second is mild COPD. Many articles have used the term mild COPD to address it as an surrogate marker for early disease. But that is not the thing. We should not use mild COPD to identify early COPD because early COPD is a biological process, as we studied previously. It's not a clinical identity, but mild airflow limitation is a clinical identity. Third, COPD in young people. COPD in the age group of 20 to 50 years of age. Okay. Previously, in previous guidelines, we used to consider the age group of more than or equal to 40 to diagnose it as COPD. But this is a newer thing which they added, that is COPD in age group of 20 to 50 years of age. That is COPD in young people. But to call this term, the patient should have confirmed spirometrical diagnosis. That is post bronchodilator FEV1 by FVC should be less than 0.7 and should have the symptoms and should have the risk factors like smoking or abnormal lung development or exposure to noxious particles. Only if it satisfies all the spirometrical criteria, only then if the age group is between 20 to 50 years of age, we consider it as COPD in young people. That is the third important term. Fourth, pre-COPD. Listen, this is a very important term. This term has been recently proposed to identify individuals, importantly of any age, who have respiratory symptoms of COPD with or without detectable structural and or functional abnormalities in the absence of airflow limitation, and who may or may not develop persistent airflow limitation. Okay, this pre-COPD paragraph I will have to divide into four important terms. One, the patient should have respiratory symptoms. It is very important thing. Respiratory symptoms like cough, wheeze, exertional dyspnea, pededema in cases of carpal tunnel. This patient should have respiratory symptoms of COPD. Second, there may or may not be structural abnormality or functional abnormality. That is second thing, may or may not. Third, there should not, in the absence of airflow limitation, means there should not be any airflow limitation, means the spirometry, the FEV1 FVC should be more than 0.7. And fourth, these patients may or may not develop COPD in the future. Okay, understood? Four important points in this. Patient should have respiratory symptoms in the absence of airflow limitation, may or may not have structural and or functional abnormalities, and these patients may or may not develop to COPD in their future life. Understood? Four important terms. Coming to the management of Goal 2022, here we use ABCD assessment tool for COPD. Before we start the management, we divide the patient into group A, B, C, and D. How do we divide it? First, the patient who are confirmed spirometrically by diagnosis of COPD, we take them, we assess the airflow limitations based on the predicted FEV1. We divide it into Gold 1 if the FEV1 is more than or equal to 80%, Gold 2 if it is 50 to 79%, Gold 3 30 to 49%, and Gold 4 less than 30% of the FEV1 predicted. And then we divide into A, B, C, and D. We take mainly three criteria, mainly three. What are those? One is moderate or severe exacerbation history. Second is symptoms. Symptoms you have MRC 0 to 1, and category, that is CAT, that is combined assessment test. We take into consideration these three important things. The patient has 0 or 1 moderate or severe exacerbation, there should not be any hospital admission, and the symptoms are MMRC 0 to 1 and CAT combined assessment test less than 10. We put to the patient in group A. Group B, 0 to 1 moderate or severe exacerbation history, no hospitalization, MMRC more than equal to 2, and category more than equal to 10. We put him in a group B. And group C, if there is more than equal to 2 exacerbation or more than equal to 1 leading to hospital admission, if the patient has hospital admission, directly he comes either in the group C or the group D based on the symptoms. Okay, Symptoms, if MMR is 0 to 1, group C, and if MMR is more than equal to 2 and CAT if more than equal to 10, it directly comes into group D. This is ABCD assessment tool for COPD. Coming to how to initiate the patient. How to initiate the patient pharmacologically. Means it is when the patient comes to you for the first time in the OPD, how to start the treatment. We again divide because in the previous slide we have studied how we put the patient in group A, group B, group C and D. So here when the patient comes, if the patient is under group A, we start him on any bronchodilator. It could be either short acting, long acting, anything. We can start the patient on any bronchodilator. The patient is in group B, we start on a long acting bronchodilator. It could be either long acting beta 2 agonist or long acting muscarinic antagonist. The patient fits under group C, that is long acting, we start the patient on long acting muscarinic antagonist. And if it fits on the group D, we add long acting muscarinic agent or long acting muscarinic antagonist with LABA or ICS with LABA when if the eosinophils levels are high. Okay, this is group A, B, C and D. Means this is how you initiate a patient on bronchodilator or other therapies. Once you initiated the patient on bronchodilator therapy, then you follow him up. How do you follow? We follow him up on 3 months, or depends on how you want to follow it up. If the patient is doing well with your initial pharmacological management, then continue it. Don't stop it, you should continue it. But if the patient still continues to have dyspnea, if the patient is taking LABA or LAMA, we'll combine LABA with LAMA. Or if the patient is taking LABA with ICS and the eosinophils levels are low, we shift it to LABA with LAMA. Even with LABA with LABA, the patient continues to have dyspnea, we change the inhaler device or we change the molecules. And we need to investigate for other causes, because even non-respiratory causes can also cause dyspnea, like anemia, severe anemia, congestive heart failure, renal failure, even they can cause dyspnea. So this is how you follow the patient with COPD patient with persistent dyspnea after initial pharmacological management. The patient continues to have repeated exacerbations. Then this is the on the right hand side, that is the flow chart. The patient is on LABA or LAMA. Then if the patient eosinophil levels are high, or if the patient has moderate exacerbation, we put the patient on LABA with ICS. Even with that, if the patient continues to have exacerbation, we put patient on LABA, LAMA with ICS. That is triple drug therapy. Even with that, the patient have exacerbation. In the former smokers, we give azithromycin 250 mg BD thrice weekly, or we go for roflumilast if FEV1 is less than 50 and the patient is a chronic bronchitis. The patient eosinophil levels are normal, we start the patient with LABA with LAMA, and if the eosinophils levels are still continues to be less than 100, we go with roflumilast or azithromycin. The patient levels are eosinophils levels are more than equal to 100, we go for LABA with LAMA with ICS. That is triple drug therapy. This is how you follow up the patient. Coming to the single inhaler triple therapy, that is SITT. It is a combination of LABA with LAMA with ICS. So what are the indications we use for the patient which we put on SITT? COPD patient with uncontrolled with dual therapy, non-smoking COPD, COPD with frequent exacerbation profile, or COPD with history of ACO, that is asthma, COPD, or these are the 4 major conditions where they put the patient on SITT. Okay, single inhaler triple therapy, because it includes LABA, LAMA with ICS. Okay, thank you all for your patience listening. Please like, share and subscribe. If you have any doubt, please leave it in the comment box, and if you want me to improvise, I can do it. Okay, please leave it in a comment box. Thank you all for your patience listening. Thank you.